This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Owen Walker. In this episode, we're going to be speaking with Dan Dutfield on the life of an advanced clinical practitioner. So in the conversation, we wanted to really look at the ACP role as a pivot and indeed as an option for paramedics that can and potentially will pivot into different types of work, aligned adjunctive work, such as the ACP role. So with Dan in the episode, we're going to explore what training looks like in the ACP role. We're going to look at the autonomy involved within the role. We're going to look at the various specialisms you can pivot into within the ACP pathway. And we're also going to look at what Dan's learned along the way as this career progresses. Welcome to the podcast, Dan.
Thank you very much for having me along, Owen. It's a great chance and an opportunity to speak to your listeners. Thank you.
Firstly, Dan, could I just get you to unpack your background, as you have had a very varied career, and you came through the system as one of the old ECPs or emergency care practitioners from London. Could I get you just to speak to your background?
Yeah, so as you know, I'm getting on a bit now. I joined London Ambulance Service back in 1992, and after about 3 years, worked my way up to paramedic. Worked in sort of a tough area of South London in Brixton and Streatham, which was just amazing. Then became a team leader, leading a team, supervising, mentoring some of the junior staff coming through. And like yourself, I spent a couple of secondments on London HEMS, which again, another amazing opportunity. Seeing some of the really complex traumas has taught me so much. And then we had the ECP scheme, the Emergency Care Practitioner, which unfortunately, after about 4 years, the scheme folded in London. I think, it was a fantastic scheme. It did what it said on the tin. We had very good success rates of discharge, safe discharge. And, London Ambulance Service being London, it always puts in place really good governance, I always found. But I think, we had a team of 60, and I think what with the governance required for that role, it just became too much cost to run and manage, I think, which unfortunately it sort of led to its demise. But it was a good role, and that was certainly a stepping stone onto the role of ACP, which is what I'm doing now. But after I left London back in 2017, I went off and worked in the Middle East for 4 years in Abu Dhabi, and again out there I worked on HEMS, managed and set up a clinic at the airport, looking after some of the sick people coming off aircraft. And then in 2017, 2017, I came back from the Middle East. I went out in 2012, and then joined Ipswich Hospital, SNF, so East Suffolk North Essex Foundation and Trust, as a sort of trainee ACP. And I was quite lucky in that respect that I came in with a master's already. So that meant that aspect was completed. So I wouldn't say I was up to speed with the other guys doing the job, but I certainly hit the ground running because I had that background of ECP in London, which was a really good stepping stone.
So we'll dig into what an ACP is, but as you just quite rightly said there, I think an MSc is a prerequisite for the role, and that's an important differentiator and indeed a step for what would otherwise be paramedic practice that doesn't necessarily require a master's. But could you just run us through what actually an ACP is, and indeed how it differentiates from other roles in medicine?
Yeah, I mean, ACP is not a protected title, so anyone can call themselves an advanced clinical practitioner. they do cross sort of quite a few speciality as well. So I think in our trust we've got surgical ACPs, geriatrician, geriatric ACPs, and orthopedic as well. And obviously the role I do is emergency medicine advanced clinical practitioner. So although we're not protected, we work and become members of Royal College of Emergency Medicine, which I'll just call RChem. Everyone calls it RChem. So you become a member of RChem, an associate member, and you pay your fees, which is currently around £340 a year. And that gives you access to a portfolio, which we'll chat on a bit later. But so an ACP in the emergency department is you come in, you join your RChem, become a member, you get access to the portfolio. And an advanced practitioner, once they're qualified under the RChem system, you're qualified to that of an ST3 speciality doctor. So in the emergency department, I'm expected to meet the same standards and do the same role as an ST3, which is a senior doctor within the emergency department. And the Royal College of Emergency Medicine, I don't know if you know, but they've been running for around about 50 years now. And they set all the standards, the training and the education in the UK for emergency medicine physicians.
Dan, that's fantastic. And like you said, there's not only overlap, but you can really call forth your experience as a paramedic, but bring it into and in line with, as you said, the prerequisite for the RChem academic pathway. But could you maybe then speak to, because as paramedics sort of mature in their life cycle and want to pivot into some of these roles, it would be helpful for them to really know what kind of cross-section of cases that you see, and indeed how you're used within the emergency department. Could you speak to that?
Yeah, I mean, I can only speak for the department I work in, and there'll be similarities across England, I imagine. But so a typical day for me, I'll give you an example of last Friday. I was on a 7 o'clock till 5 o'clock shift. You'd go in the morning, and this is, over the night shift. So it's been busy, and the usual problem, there's ambulances outside and there's people in corridors just because of the demand at the moment. But you'll go in the morning, and I normally introduce myself to the registrar who's run the shift over the night. And we'll have a look at the screen. We'll have a chat about if there's any sort of immediate cases that need to be seen in the department. And quite often they'll signpost you to, can you go and see, Doris in cubicle 7 who's got some breathing difficulties and need you to go and assess her. So, you do that. And last Friday, my typical day, I went in, there was nothing, sort of outstanding that need to be addressed there and then. So I went round to our ambulatory care area, which is, where you see allegedly the less serious cases tend to be. And I saw a couple of patients. One of them was just a standard earache, ear, nose and throat issue. So just a typical examination, prescribed some antibiotics and discharge. The next patient after that was just someone with chest pain. And again, as an ACP or as a doctor, you're expected to manage them from A to Z. So it's, you review the bloods, you use your heart scores, you look at the ECG, and you make a clinical decision on that patient. Do they need to come in to to medicine for ongoing echo or further tests, or can you safely discharge them with possible GP follow-up? So, it's fairly standard stuff. And then after that, one of the sisters came up to me and just said she's got a lady in the waiting room who's just come in with an ankle injury. Now, quite often the minor injuries will go to our urgent treatment centre, but she expressed a little bit of concern because it was a bit out of shape, this ankle. So I had a quick look, and yes, she was right. It did look out of shape. It's, you just sort of think to yourself, this is probably going to need pulling and the cast. So we ordered an X-ray there and then. And she had a really nasty dislocated trimalleolar fracture. So I grabbed one of the doctors. We moved this lady around into resus. Between us, we decided my doctor colleague was going to do the reduction and I was going to do the sedation. So I don't know if your listeners know, but you need to be a prescriber as well once to be an ACP. So I opted for ketamine. Several reasons. One, I like the drug. I've got experience with it. It's a nice drug. It's a good analgesic and it gives lovely smooth sedation. apart from in this case when she got a bit of dysphoria, waking up, which was interesting. So my role in that case was I consented the patient. We discussed the drugs. We work out the risk. We set up the bay. I run the sedation autonomously, and then my colleague pulls the leg, and it was casted. And unfortunately, it didn't reduce. So when orthopedics came down, they asked if I could resedate to have another go. And that's rare. That doesn't normally happen. They normally go back. So it's a bit annoying. But so this time we had another go. This time I used propofol, second choice, because it just gives you sometimes a bit more relaxation. So again, I went through all the procedure. Patient was wonderful. We gave fentanyl, propofol sedation. The orthopedic team did the reduction this time, and it went back lovely. And managed her for an hour just to make sure she was safe post sedation, and then she went off to the ward. Then I had probably another mundane case in between that. I say mundane; it's easy to say mundane when you know what you're doing, or sometimes if you don't know what you're doing. But very straightforward case. Sent home, and then the consultant came up to me after lunch and said, "Could I go to resus? There's a pre-alert coming in 10 minutes." And that's quite typical, as one of the senior team in the department, and the ACPs tend to be classed as that because of the level we're expected to reach. It was a 50-year-old lady in DKA with possible sepsis. She had an acute kidney injury. She was musing of 9, really sick, very dehydrated. And again, that's my role in that, was to start all the treatment, working with a nurse, just myself and a nurse in the resus bay, requesting the imaging, prescribing, discussing with ITU, getting them down for an opinion because she'd sort of breached the threshold for their involvement, and managing that case for a couple of hours, because you get a sick case like that, you tend to not leave that area really while you're managing them. That's a sort of a typical day in the ED really.
Yeah, and there is the real range and spectrum of cases there, and like you said, a range of autonomy actually as well, with the ability, I'm guessing, to be able to discuss cases if you want a second opinion, or indeed just a someone to chat a case through with. But could you maybe speak to the main roads to being an ACP? Sort of, it'd be helpful maybe for listeners to know who your colleagues sort of, because I know the paramedic practice isn't necessarily the only route to being an ACP. Could you maybe sort of discuss where your other colleagues have come from and their backgrounds as well?
Yeah, absolutely. So we've currently got 9 ACPs in our department. We did have 11. One's a guy called Kevin. Some of you listeners may know him. He's moved on to Abu Dhabi at the moment, and he's teaching in a university out there. So he's took his family off to have some fun and do something different. And one of our other ACPs, who's superb, a guy called Andy, he was a nurse background. He's left, he's retired now, but again, his background was emergency nurse practitioner. He's done some community roles. So now we've currently got 5 nurses and 4 paramedics, and our nurses come from a background. One was a sister in ED, so again, very experienced. 2 of them were EMPs, emergency nurse practitioners, with, and this is where the role is really good, because there's a mix. You've got these colleagues to call upon. If I see a minor injury, I would always run to them because their knowledge is just far outweighs mine. And then we've got some paramedics as well. We've got 4 paramedics, myself, and my background. We've got a guy called Pete, who is a paramedic who's done HEMS, again, very knowledgeable, very qualified. And one of our newest paramedics, who's been with us for a year now, I think she's probably 5 years post-qualified as a paramedic. So I would say quite junior coming into the role. But in the last year has just proved herself to be outstanding. It's really very, very intelligent, picking up the role really well. And I think probably that comes from the background that the paramedics are now doing degrees. So they have that, they have that background-based knowledge before they join these roles. But I think, 5 years in is probably a good time span to spend before moving into a role like this. You don't want to do it too early. But you can also come from, physiotherapists can also become ACP. So nurses, paramedics and physios, I think, is the current sort of scope of practice you can come from.
So looking at the training for a second and how the training plays out as an ACP, was it quite similar to the ambulance service, or was it quite different? I know it tracks on to the RCEM, so the Royal College of Emergency Medicine criteria, or indeed academic portfolio. Could you speak to for paramedics that may or may not know how that training looked like comparing to the ambulance service?
Yeah, so you find a department that wants ACPs and you get your job, and if you want to go down the route of work of qualifying credentialing for the Royal College of Emergency Medicine, like I say, you become a member of RCEM, you get your portfolio, and normally you'll be assigned a supervisor, which is got to be a consultant, and they have to have achieved some of the training to supervise ACPs as well. So it's very similar to what doctors go through in terms of the portfolio. It sort of mirrors across really, but the portfolio is your sort of what you need to achieve, and in that portfolio, I mean, it's changing this year to a new portfolio, but the portfolio I'm currently working on and the credentialing this year, it's got 200 competencies you need to achieve. And they can range from, like we were talking earlier, diabetes to mental health, safeguarding, procedures, sedation, chest pain, trauma, and it covers max fax trauma. So it's a really complex, involved portfolio, and it's quite descriptive. So we call them tickets, but you have these workplace-based assessments, and there's varying degrees you can have. You have to get so many where the consultant's sort of standing behind you, watching you assess a patient and do a procedure or make a decision about a chest pain. Some of them are skill based. You have to achieve certain skills like fascial block and abdominal assessments, etc. So you get these sort of 200 assessments, and you'll probably want 3 or 4 observed assessments for those. So you're doing between sort of 6 to 800 assessments before you can say actually you've achieved the standard. And then once you think you're ready, and being ready means you've got your masters, you've got your prescribing, you're up to date with your advanced trauma life support, pediatric advanced life support, your adult life support, and all them courses. Once you've got all them, you can then apply for credentialing. And that's a process in itself, which probably takes another 6 months to get your portfolio up to scratch. And you have to have done an audit as well. And then you submit your portfolio to RCEM, and you pay your fees to have your portfolio assessed, and that takes place twice a year, these windows. And then someone scrutinises it. And one of our colleagues in ACP actually does this as a sort of one of our roles. And they take about 8 hours going through your portfolio. And they either deem you satisfactory, not satisfactory, or limited resubmission. And so I've just submitted my portfolio. So I've been 5 years working on it, and I've got a limited resubmission. So there's about 10 extra areas they just want me to write some reflection on because they felt that was lacking. So no biggie, which is great, So that's been resubmitted in March. So yeah, that's pretty much how it works. Yeah.
That's a real variety of not only of training and education, but like you said, mentorship and OSCEs and assessments. It's a plethora of portfolio experience. But we touched on autonomy already, Dan, and I think you were inferring, how senior the role is, and there is trust in that, that you're not only competent, but that you refer, you discharge, that you prescribe, and that you also lead on in certain departments. Is there, I suppose my question is really, is there capacity to consult? Is there a mandate to consult with the consultant as far as when you're discharging patients, or is there ultimate autonomy with sort of no one really looking over your cases? How does that where does that autonomy start and end versus clinical governance in your practice?
Yeah, it's a good question. I mean, it's how it differs from the ambulance services. You're kind of on your own, aren't you? When you're on an ambulance, you're making that decision. And yes, there's support and the device lines, but ultimately it can feel quite a lonely place. Now that differs in the emergency department because there's always seniors there. So although you're working completely autonomous, and during the shift, if you see 10 cases, you might want to go and discuss one or two of them with a senior, because you're thinking, do you know what, I'm scratching my head here. I don't know what's wrong with this patient. Or it's, part of being an ACP is about being mature and knowing your limitations. And I think knowing when you think, do you know what, I need to speak to someone about this case. This is a tricky one. And so you've always got, in hours, you've got a consultant face to face. Out of hours, there's a consultant on call, and you've always got your senior registrar as well. They can be up to an ST6 level. So the final, reaching their final stages of registrar, pre-consultant level. So we are autonomous up to an ST3. So 90% of the cases we see, we just manage completely on our own. Like the sedation one, I didn't need to go and discuss that. It's just something I do as my job. But yeah, the tricky ones, the more complex ones, the ones that require, speciality imaging, you've got your consultants, your registrar, you'd always seek their peer support and advice. And then you've got speciality as well. So you might phone, the nephrologist or medicine consultants sometimes when you're referring a patient, and have a chat with them. And sometimes that changes your clinical course or your treatment, so it doesn't feel lonely like it does on an ambulance. It's nice in the fact that you work with absolutely amazing colleagues, and they come from different backgrounds and different cultures themselves, and bring their own areas of expertise, which you're just pulling on and learning from all the time. And and vice versa. They've not worked pre-hospitally, so we can be that link, that bridge. Sometimes you get the rolling of the eyes and the eyebrows going up about why they're bringing this rubbish in, and you can be that link and explain, well, because it's not so easy discharging people in the community like it is here. So it's interesting, really interesting.
To your mind, Dan, like you said, you've been in post for approximately 5 years now. How has the role evolved over the last 5 years?
I mean, the job itself hasn't changed. We're still, you just become more senior and, more qualified, and probably better at making decisions about patients. But I mean, the role itself, we represent 10% of the Royal College of Emergency Medicine now, which I think, considering the trial ACP role was in 2015, completed in 2017, I think to have and that's over 1,000 members now, 1,000 ACPs under the RChem. So I think that's pretty impressive. And the numbers are expanding. The new portfolio is being rolled out this year, so it's changed both for doctors and ACPs. They've just upgraded it, and it's a new system. And I'm not completely au fait with that system yet, but it's something I will get my head around. I think confidence is growing within the role as well across the sector. So, in the early days, who are you? What do you do? You're not a doctor. You haven't been to medicine. The social media skeptics, if you like. But now, confidence is growing. It's recognised. We have very little grief now across our trust, even when speaking to speciality. So I suppose the role's changing in the respect that we're now fully embedded. I think we're here to stay, and we give a constant across the department. We're there all the time. So I think that's quite nice.
So Dan, just looking at the paramedics that are considering the ACP route as an alternative pathway, would you advocate it as an attractive option to paramedics that are looking around?
Yes, I would. It's a fantastic role. It's not an easy role. It's a tough role, and I joined it after 20 odd years, and you think actually I'm a pretty good paramedic, and I probably was an okay paramedic, but you do these roles and then you think, actually, the more you know, the more you realise you don't know. And like medicine and paramedicine, it's every day is a learning curve, and you just realise, actually, after 32 years, I still feel quite junior, to be honest, within this job, which is some people would think, won't believe you when you say that, but it is a tough job. So I would recommend this role to any of my colleague paramedics out there. What I would say is at the moment, an ACP, there's not really anywhere else you can go once you've qualified within the emergency department, and the job is relentless. Although you say about sort of being stuck on a truck, and but at least on a truck you do get a bit of downtime. And I'm not saying it's not busy on a truck, because I've done it for many years, but a 10-hour shift in A&E is 10 hours, 30-minute, 40-minute break, and you are patient to patient to patient, and there's always a waiting room for the people. So it's hard. So I would say to my paramedic colleagues, if you're thinking about this role, I would spend some time enjoying the role as paramedic, because that's what you signed up to do. It's a fantastic role. And I loved being a paramedic on the truck. It was brilliant. I got so much to be grateful for, and so all the people I work with and the universities I've studied at. But yeah, I would certainly look at this role. It's brilliant. It's a level. It seems to be a natural progression, a next level up of autonomy and expanding your skill base and knowledge base. But I would just do it probably a bit later on, not when you're too young, because you're going to be spending a lot of time doing this job, and this is it really for me now. I'm sure there are other roles out there people can diversify to later on, but yeah, so spend a good bit of time on a truck and enjoy it and get what you can out of it. Do different roles within an ambulance service, and then I would say once you've got some real experience under your belt, this is a perfect role for you.
So looking at the governance piece, Dan, could you unpack what governance looks like in the ACP role?
Yeah, certainly. So, like we've said before, you've got your RChem, and they sort of define what EM medicine is in the UK, and the standards and the training and the education, and they have some great RChem Learning has an entire platform, just hundreds upon hundreds of videos and teachings and assessments you can do. So that's really good. Your governance comes from, like with the ambulance trust, your governance comes from your senior, your consultants and your trust governance, systems that are in place. We have, like we said, we've got consultants on call or face to face to provide that clinical governance. We've got speciality as well that provide the governance for complex cases. So within our department, we have a teaching every week as well. Every Wednesday, we have a 2.5-hour teaching, consultant led. Last week, where geriatrician came and did an hour's lecture on geriatric medicine, which was just amazing. The week before that, we had urologists come and do an hour's teaching. So it's, that provides a huge amount of governance. And then you've got your peer support as well. So, it's multifactorial, the governance. It comes from the consultants, it comes from RChem, and it comes from speciality teaching. So yeah, compared to the ambulance service, I'd say there's more opportunity to, that layer of governance is probably greater than it is within the ambulance service.
Yeah, like you said, the oversight and the peer-to-peer support, and indeed, you're right, the teaching as well. Could you speak to the future of the ACP role, and indeed maybe just the future that you see within your department? But if you have any thoughts on where you see sort of the ACP role on more of a national level going, where do you see it going?
I guess it comes back to confidence as well. I think nationally, I mean, you'll be getting ACPs, turning up to conferences and speaking and presenting, papers they've written and stuff. I guess that's going to be occurring soon, if it's not already. I guess it's more about just expansion. I think you may become specialists within your department. So, I'm quite interested in ultrasound. I'm doing my level 2 ultrasound course in March. So you could become subspecial interest within your department if you like. Our EMPs, ACP backgrounds, their knowledge of minor injuries outweighs probably most people's, and therefore that level of support they can provide is there for others. And then a lot of our ACPs within our trust as well, they're ALS instructors, PALS instructors, ATLS instructors now. So they're providing that level of speciality as well. So yeah, it's interesting, but seems to be working really well.
And just finally, Dan, as we come into land, could you maybe speak to, we did touch on the education requirements for the role, but as we see sort of more and more paramedics migrate into the role as an attractive proposition, what could you speak to sort of the mandatory requirements? So Do you have to have a master's, or are they willing to sort of support master's study when you get into the role? And are there any other prerequisites that they ask for?
Yeah, so you need to be registered with your healthcare professions council or your equivalent if you're a nurse, with your nursing body. Uh, you need a master's, but you need a master to credential. So you in our trust, I was sort of the odd one out because I came with a master's, but the majority of my colleagues have been doing their masters whilst fulfilling the role. So you're allocated time to go off to university and get your masters. Most people now are coming in with a BSc because that seems to be the prerequisite for paramedics and nursing anyway. But as I say, I did a diploma at Hertfordshire, which to this day is probably one of the best awards I've done because it covered anatomy and physiology, pathophysiology, pharmacology. So that was a really good grounding, which I think probably the paramedic degree course touches on now. But yeah, you do need a master's. That can be done whilst you're going through the process of qualifying. Most people spend up to about 5 years to credential, just because of the workload. You've got to do your ATLS, your PALS, your ALS. You need to do your prescribing and your masters. So all of those. It's it's a lot of work, and then your portfolio as well. So, and that's pretty much what you need to become an ACP if you want to qualify and credential with Royal College of Emergency Medicine.
Listen, it's a fantastic pathway, Dan, and like I said, a really attractive proposition to those people that are just trying to take their career into a different domain, learn, like you said, every day is a school day, learn as they go, and indeed put themselves under some applied pressure in different ways, and learn and become autonomous in a variety of ways. But I just want to thank you for the last half an hour because it's extremely insightful getting your perspectives, having done an array of pre-hospital jobs and now in hospital ACP routes. So I just want to thank you for your time.
You are welcome, Owen. It's been a pleasure. Just so your listeners know, the Royal College of Emergency Medicine website, under training and careers, under the menu, there's a whole section on ACPs, which will give them loads of insight, and there's some videos on there as well. So if they want any further info, everything's on there.
That's fantastic. We'll put that in the show notes actually, so people can check that out. Fantastic.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.